Temporary cardiac pacing is a method where a small electric current is delivered to the heart to initiate myocardial contraction artificially. When intrinsic stimulation of myocardium is insufficient to maintain hemodynamic stability due to disturbances in the conduction system. A temporary pacemaker is used to treat a bradydysrhythmias or tachydysryhthmias when the condition is short-lived or to bridge until a permanent pacemaker is placed. There are various methods of performing temporary cardiac pacing. These are transvenous pacing, transcutaneous pacing, transesophageal pacing, transthoracic pacing, pacing through pulmonary artery catheter, and pacing by epicardial wires. Transvenous pacing is by far the most commonly performed technique for temporary cardiac pacing, particularly in the ICU setup. Transcutaneous pacing is another commonly performed temporary pacing method in the ICU setup, particularly during emergency situation when little time is available, for example during cardiopulmonary resuscitation. Indications of temporary cardiac pacing. Temporary pacemakers are indicated as a bridging procedure in almost all the conditions where permanent pacemakers are indicated. There are certain other conditions where temporary pacemakers are used alone for a brief period until the underlying risk subsides. The indications may be therapeutic or prophylactic. The therapeutic conditions are patient having acute myocardial infarction and symptomatic bradycardia, which is medically refractory, new bundle branch block with transient complete heart block, postoperative complete heart block, symptomatic congenital heart block, Mobis type 2 with acute myocardial infarction, new bifascicular block, bilateral bundle branch block and first degree AV block, symptomatic alternating bundle branch block. For the treatment or prevention of tachycardia in conditions like bradycardia dependent ventricular tachycardia, torsades de pointes, long QT syndrome, treatment of recurrent supraventricular tachycardia or ventricular tachycardia. The prophylactic conditions are pulmonary artery catheter placement with left bundle branch block, new atrioventricular block or bundle branch block in acute endocarditis, cardioversion with sick sinus syndrome, post-defibrillation bradycardia, counteract perioperative pharmacological treatment causing hemodynamically significant bradycardia, post-cardiac surgery atrial fibrillation prophylaxis, post-orthotopic heart transplantation. Contraindications of temporary cardiac pacing. There are no absolute contraindications to the use of temporary cardiac pacing. A few relative contraindications do exist for particular type of temporary pacing, which however can be overcome by using different method of temporary pacing. The conditions are patient with severe hypothermia, distortion of vascular anatomy or bleeding disorders, cardiac glycoside toxicity, presence of tricuspid valve prosthesis. Atrial pacing is contraindicated in presence of atrial fibrillation and multifocal atrial tachycardia. Different types of cardiac pacings. Transvenous pacing involves intracardiac placement of pacing wire through central venous access. The preferred route for central venous access is internal jugular vein followed by subclavian and femoral veins. However, other major veins like the external jugular vein, brachial vein can also be used. The lead are placed into the endocardium of atrium and or ventricle. The right atrial appendage and right ventricular apex provides the most stable positions for lead placement. The electrode are placed under the ultrasound or fluoroscopic guidance. For insertion of electrodes, flow-directed catheter can also be attempted using pressure or electrocardiography guidance. Temporary transvenous pacing is dependable and well tolerated by patient. Both the atrium and the ventricle can be paced in a synchronized way, leading to improved cardiac output. However, this procedure needs expertise, as in inexperienced hand It could be a time-consuming process and a higher incidence of complications. Transcutaneous pacing. This is by far the simplest and quickest technique where heart is paced by application of external pads over the chest wall. The large external pads are typically placed anteriorly over the palpable cardiac apex and posteriorly at the inferior aspect of the scapula. The negative electrode that is placed anteriorly and the positive electrode is placed posteriorly. The positive electrode can also be placed at the anterior right chest below the clavicle. Sedation may be required as this procedure is often uncomfortable to the patient. This technique is commonly used in an emergent conditions until temporary transvenous pacing can be instituted. Transcutaneous pacing facility is now available on most modern defibrillators. Pacing by epicardial wires. This is commonly practiced technique for intraoperative and postoperative management of arrhythmias associated with cardiac surgery. The epicardial wires are placed during intraoperative period under direct vision. This is a very reliable short-term technique where atrium and/or ventricles can be paced. Development of inflammatory reaction around the wire and the myocardial interface and failure to sense and capture after a few days, typically after 5 days, are major problems associated with this technique. Transthoracic pacing. In this method, pacing wires or the needle is directly introduced to the ventricular wall through the thorax by piercing the thoracic wall. Transcutaneous pacing has replaced this method. Transesophageal pacing. This is the newest technique available. This relatively non-invasive and well-tolerated technique requires introduction of pacing leads through the oropharynx to the esophagus, where the electrodes are paced against the left atrium. A modified esophageal stethoscope is used for this purpose. Pacing capture should be confirmed by presence of peripheral pulse as detected by plethysmogram or invasive hemodynamic monitor. Procedure of temporary cardiac pacing. Standard aseptic precautions are to be taken. Position of the patient should be supine. The skin at the site of central venous access should be infiltrated with local anesthetic. Standard techniques for central venous catheter placement should be followed. Seldinger's technique is used for vascular access. 6 or 7 French size sheath is inserted through the femoral vein or internal jugular vein or subclavian vein. Ensure the electrode tip is J-shaped. The electrode is advanced under ultrasound or fluoroscopic guidance. The electrode should be advanced in a such way that the tip is directed towards the free wall of right atrium. Pass the wire with the help of rotational movement between the thumb and the index finger through tricuspid valve to position it along the apex of the right ventricle. If the difficulties are encountered during the positioning of electrode tip at right ventricular apex, then slide the wire into the right ventricular outflow tract and pull the wire backwards to push it again towards the apex with the tip at its downward angle. If unable to capture satisfactorily, then pull back the pacing catheter to the right atrium and start over. Set the ventricular rate to 10 per minute above the patient's own ventricular rate or 70 per minute. Once the pacing threshold is determined, the pacemaker is set to deliver a pulse of at least twice the threshold. Normally, sensitivity is set to 1 to 2 mV. If neither spikes nor output is seen, then check pacemaker connection along with normal functionality of the pacing generator. If spikes are seen without any output, then check the position of the pacing wire and reposition if it is necessary. Fix the wire to the skin by suturing close to the point of insertion once the position of the electrode is confirmed and satisfactory capture and output. The area must be covered with antiseptic dressing. Continuous ECG monitoring is recommended for endocardial lead placement. Fluoroscopy is desirable but not necessary. Post-procedure care. Patient is advised to keep the lower limb immobilized and not to sit if the temporary pacemaker lead insertion was done through the groin. At least one ECG after placement should be done. QRS complex should appear like left bundle branch block morphology with lead paced at the apex of right ventricle. Immediate chest X-ray to ensure lead placement and to rule out the pneumothorax. Daily threshold check to ensure proper capture and sensing. Separate IV assess if drug needed to administer in central line. Daily physical examination should be done to rule out pericardial rub, asymmetric breath sound, hypotension, jugular venous distension, fever, like that. Daily dressing change with antibiotic ointment. Battery status of the pulse generator is very important. Pacemaker dependent patients who are not on cardiac monitor may die unattended if the battery is exhausted and not replaced timely. If there is no contraindication, 5000 international unit of subcutaneous injection heparin twice daily is given to prevent deep venous thrombosis, particularly when femoral vein route is chosen. If permanent pacemaker is required, discontinue heparin 12 hours prior to the procedure. Complications of temporary cardiac pacing. Failure to capture is a common problem which can be solved either by increasing the pacing output or by repositioning. Failure to pace happens when the pacemaker fails to deliver a stimuli which is manifested by absence of pacemaker spike on the ECG. Dislodgement of pacing wear is another frequently encountered problem. Knotting of the lead wear may also happen. Ventricular arrhythmia, particularly after post-AMI, temporary cardiac pacemaker insertion, which may occasionally require removal of lead or repositioning. These arrhythmias, however, subsides when manipulation of the lead has ceased. Development of septicemia, most frequently by Staphylococcus epidermidis, occurs when pacing wear is left in situ for more than 48 hours. Thromboembolism may occur in patients susceptible to deep venous thrombosis. Avoidance of femoral route along with deep venous thrombosis prophylaxis should be considered. Pneumothorax or hemothorax during vascular access for transvenous pacing may occur. Transcutaneous pacing is painful. Also, ventricular capture is often erratic in this method. Cardiac perforation can be produced by pacing leads, which may rarely produce cardiac tamponade. There may be local trauma and hematoma formation also.